welcome to this MedEClasses lecture series on delayed puberty in girls. And this is part of our initiative, a monthly initiative in which we propose to cover the entirety of pediatric endocrinology from a pediatrician and pediatric trainee perspective over the next 36 months. I'm pleased to be joined by Dr. Vibha, who is a consultant in pediatric endocrinology at Regency Health, and Dr. Dhwani, who is a fellow with us at Regency Center for Diabetes, Endocrinology and Research. So this is a very, very important topic. And what are the key things, Dr. Vibha, you have to understand in terms of when you are evaluating a girl with delayed puberty compared to boys with delayed puberty?
So most in compared to the boys, the presentation, the cause of the delayed puberty in girls is mostly physiological, is not physiological in comparison to boys. So we have to firstly rule out the systemic causes and other pathogenic causes or the organic causes in comparison to boys.
So although we have got lesser number of girls who come to us with delayed puberty, we need to be more worried about that in that perspective. So Dhwani, in your experience, what are the common presentations or common causes of delayed puberty of girls?
So again, as ma'am has mentioned that when you have a girl with delayed puberty, you have to be wary of it being a pathological cause. However, we've seen that about 1/3 of these children are actually physiological and self-limited delay of puberty. However, the most common causes that we encounter are probably hypothyroidism, Turner syndrome that we commonly see in our day-to-day clinical practice.
So
Systemic.
celiac, hypothyroidism, Turner syndrome, these will be a very, very common. So we have this 13-year-old girl who had presented to us a few years ago with concern for delayed puberty. She had stage 1 breast development and stage 1 pubic hair development. So parents were concerned that she was not having puberty. She was short for the age, weight was reasonable, and somebody had done a workup which showed a low level of LH and FSH. To compound the matter further, ultrasound had been done by the referring physician who found an absent uterus. Now, this was a very devastating scenario for the parents. They were very concerned about the puberty, breast not being there, and ultrasound showing an absent uterus, which was an entirely disastrous scenario from that regards. But what we need to understand is that 13 years is just the edge in terms of the time when puberty should happen. And in this scenario, clearly, we need to understand that when the breast is developing, the uterus will take time to develop. And at breast stage 1, we can often miss a uterus on a transabdominal scan. So this case really highlights the importance of not doing unnecessary workup like ultrasound. And this case better would have been to wait and watch. And this is what we did. And the girl had a normal outcome subsequently. The second scenario was a 14-year-old girl with delayed puberty. Now, this is from a different perspective and dynamics. She had presented with stage 2 development with pubic hair stage 3. So what looked like that she had some development to begin with. This is what the parents said. And then the development had stopped for the last year or so. Again, the same thing was found. LH was 0.1 and FSH was 0.1. And people thought that, okay, like the first case, better to wait and watch. This was labeled as constitutional delay. Now, as I'll talk subsequently that when somebody has a stalled puberty, it has got an entirely different connotation as compared to a classical case of delayed puberty in girls. And in this case, we should be worried about our underlying cause, which was missed. And she presented later with seizures and glioma. So there seems to be a quick balance with regards to not doing unnecessary workup in delayed puberty on the one hand, like in the first case, but also to not miss a cause, which is very important. This is what we'll try to focus over the next hour or so, is to develop clinical pointers to suggest pathology and do a reasonable amount of workup without overdoing it to identify the cause from that perspective. Now, delayed puberty, as we discussed, is common in girls. Approximately 2.5% of all girls have delayed puberty. As Dhoni was talking about, 30% to 40% may be physiological, but we can have other pathologies like hypogonadotropic hypogonadism, less common as compared to boys. Functional causes like malnutrition, systemic illnesses, more common in girls compared to boys. And of course, hypogonadotropic hypogonadism with Turner syndrome leading the list is definitely common in that regards. So our role is to not unduly investigate these 30 to 40% with physiological causes, but not miss these 60-70% who have a pathological cause in that regards. all of you should go and have a look at our website learning.growsociety.in, which has got a lot of resources with related to pediatric endocrinology, including a number of video lectures which are available and courses in terms of that. We have our e-learning platform on YouTube, which has got a large number of videos as well. And we have got validated courses in terms of pediatric endocrinology, including a full hybrid fellowship program of a 2-year program, specific pediatric endocrinology course for postgraduates, which is also available. We have got a full spectrum of books ranging from pediatric endocrinology protocols, which guide the pediatricians and pediatric trainees for basic workup, to basic pediatric endocrinology, which is covering pathophysiology as well, and advanced pediatric endocrinology covering the entirety of pediatric endocrinology. Our mobile application, which I'll touch base later, is one tool which helps in terms of point of care management in that perspective. So today we're going to focus on delayed puberty in girls. We already recently had series on precocious puberty in boys and girls. That's available as part of our YouTube channel, and you can go and have a look at it. I am joined, as discussed, by Dr. Vibha and Dr. Dhwani, who will be focusing about different aspects of delayed puberty evaluation from that regards. So the key questions that a physician has to answer with regards to a girl with delayed puberty is it really delayed puberty? If it is delayed puberty, is it physiological or pathological? And finally, what is the cause of delayed puberty in that regards? So delayed puberty is defined by lack of thelarchy by around 13 years of age and lack of periods within 3 years of the onset of thelarchy. So we are talking not only about delayed puberty, but also about stalled puberty, which I said may be a marker of a serious underlying disorder from that perspective. Secondary amenorrhea, that is another marker of stalled puberty, is defined as lack of periods for 90 days in somebody who has got regular periods and 180 days who may have an irregular period. We also need to be aware that there could be anovulatory features which may suggest an impending ovarian or a pituitary failure. So this may not truly be delayed puberty, but they may suggest that there are issues which are happening. And for that, we need to understand the normal number of periods which are there. So in the first year, less than 4, 2 to 4 years, less than 6, and fifth year, less than 8, and beyond that, less than 9 is considered to be delayed puberty or anovulatory cycle. So from a pure delayed puberty perspective, no thelarchy by 13 years and no menarche within 3 years of thelarchy is suggestive of a clear-cut delayed puberty from that regards. Now, once we know that this is delayed puberty, we need to decide whether this is at 30%, this is physiological, in which we may just have to wait and watch, or maybe give a just small dose of estrogen, or a pathological cause where we need to do a lot of workup from that regards. Now, the clues to pathology, so because physiology is common, we don't want to miss pathology, is that if you have a girl who has a normal growth, normal development, and normal pubic hair, these 3 signs will say, okay, there is something wrong in the girl, and I want to evaluate further in that regard. So you can do a basal and stimulated LH levels. If they are low, they are suggestive of a pathology. On the contrary, a short girl who is looking healthy, has a delayed bone age, has no pubarchy, and has low basal and stimulated LH, that is constitutional delay of puberty and growth most likely from that scenario. Now, hormonal evaluation, we already discussed that LH is more important in terms of the onset of puberty, but FSH is more important in girls because this may be a marker of ovarian cause. The level of FSH elevation in girls is substantially higher than boys because they have a lesser amount of inhibin B. And this is something which is important from that regards. Very often we have to differentiate constitutional delay from permanent hypogonadotropic hypogonadism. So a basal LH below 0.1 and a stimulated LH below 5 is suggestive of is clearly suggestive of hypogonadotropic hypogonadism, while if basal is more than 0.3 and stimulated more than 5 suggests a case of constitutional delay of puberty and growth. Once we know that this is a pathological cause, we have to go further in terms of the causes of delayed puberty. And as I said, pubic hair and breast development give you a clear-cut clue. If you have no breast development and pubic hair development is there, this means that the pituitary is not working, but the adrenal is. This is a classical case of GnRH deficiency. Absence of breast and pubic hair suggests either there is a constitutional delay of puberty in growth or there is illness which is delaying adrenarche. Rarely, this could be because of a multiple pituitary hormone deficiency or a steroidogenic defect. If, however, there is a girl who has a normal breast development and no or sparse pubic hair, this may be the only marker of androgen insensitivity syndrome. While if everything is normal, breast is normal, pubic hair is normal, but there are no menstrual cycles, this could be a malformation. So always club your pubic hair with breast to get a good diagnostic clue in terms of evaluation. Subsequent pointers include the presence of uh, obesity, which could be an indicator of syndromes like Prader-Willi syndrome, Turner syndrome, pseudohypoparathyroidism or leptin deficiency, polydactyly, typically the Lawrence-Moon-Beadle syndrome, abnormality in hearing, which is common in the setting of Turner syndrome, charge or pseudohypoparathyroidism, brachymetacarpia, again a marker of Turner or pseudohypoparathyroidism, short stature, which could be is very severe thing of Turner or MPHD. You can also think of celiac or constitutional delay of puberty ingrowth in somebody who is short and who has a delayed puberty. Hypertension is an important clue, so always measure your blood pressure. If it's very high with hypokalemia, think of 17-hydroxylase deficiency. Otherwise, Turner syndrome, also look for forelimb blood pressure in that perspective. So once you know this is hypogonadotropic hypogonadism, the key question is it a functional hypogonadotropic hypogonadism or it's a true GnRH deficiency? And in this regards, if your growth is less, bone age is less, pubic hair is absent, that goes more in favor of a functional cause, while normal height, normal pubic hair, and a normal bone age suggests an isolated HH in that regards. And GnRH stimulated LH would also give you a clue. So functional causes will look like constitutional delay of puberty and growth, but they will look sick. While if you have a short girl with delayed puberty, no pubic hair, looking not sick, think of CDGP. Sick, think of functional cause in that regards. Always do a prolactin level systemic workup before you go ahead in terms of doing further imaging in that regards. Dhwani has already said that MRI is essential as part of workup. So when a girl comes to you with delayed puberty, do a screening test, and this I would include CBC, liver function, kidney function, celiac evaluation, thyroid profile, and prolactin. If all of them are normal, then do a gonadotropin level. In that perspective, the FSH is high, and usually when you talk about girls, there is no confusion. The levels will be somewhere like 15, 20, even 100 in that regards. This is the scenario you want to look at the karyotype. Then if you then think of other genetic causes, if the Turner is ruled out, or some other autoimmune causes in that regards. If, however, you have hypogonadotropic hypogonadism with low levels of FSH, are there any pointers to permanent hypogonadotropic hypogonadism like anosmia, synkinesia, or CNS features? In that scenario, you don't need to worry. Otherwise, you can go ahead with a GnRH analog stimulated LH. If it's above 5, this suggests constitutional delay of puberty and growth. If the level is below 5, that's permanent. And if there are pointers to HH, again, this is permanent HH. And in this scenario, you have to get an MRI and a cortisol. So evaluation is very simple. Go for simple chronic diseases followed by FSH, which will guide your evaluation towards karyotype if it's high, MRI and other causes if it's low. In that regard, we'll run through a few cases, and this is what I discussed earlier. A 13-year-old girl with concern for delayed puberty. Unnecessarily, this case had a lot of workup. Advised MRI head ultrasound was showing absent uterus. So this is a scenario in which if it's too early, wait and watch. Do not do too much workup in that regard. 16-year-old girl with delayed puberty, no breast, no pubic hair. So we're talking about CDGP versus a systemic illness right away. Height is less, so again, very, very short. Weight is also less. LH and FSH was low. And we have developed a puberty interpreter, which we'll talk a bit later, which guides your evaluation based upon that. And this tells you that this is, you need to do a proper workup in that perspective. Now, she also had anemia. She had clubbing. So this is a classical case of celiac disease. If you have short girl who is looking sick with lean, think of celiac in that perspective. 12-year-old girl with growth failure. Of course, you've got all the clinical features of Turner syndrome. There is webbing of neck. There is widening of the angle. There was brachymetacarpia, brachymetatarsia, and all features were there. Somebody did a FSH level, which was high and was advised growth hormone. Now, as Vanier said, FSH may be normal in the early age group when the bone age is retarded. But high FSH with classical features only also may suggest Turner, but you need to always do a karyotype to identify a Y cell line, which was not done in this case, and she presented later to us with abdominal lump, highlighting the importance of doing a Y line. So this is very, very important. Do a karyotype in a girl with Turner syndrome before you really go ahead and making a diagnosis from that regards. Now we have a 16.5-year-old girl with stalled puberty who had onset at 12 years and no development for the last 3 years. This is something I'm really concerned about. There's something new which has happened in this girl. She is having a reasonable height and weight. LH and FSH is very, very low. And now what we need to do here is to look at other features. There's galacturia, but her prolactin level is normal. So my first diagnosis with galacturia, with stalled puberty, is a possibility of hyperprolactinemia, but the galacturia is there, but prolactin is not high. Somebody got an MRI head which showed a large lesion. So this is a classical case of a hook effect. If your prolactin levels are exceedingly high, if you do not do a diluted sample, you will have a falsely low level of prolactin. So here with dilution, the prolactin was found to be high. This was a classical case of hook effect. 16-year-old girl with delayed puberty, breast stage 1 and stage 3 pubic hair development. The girl has a height of 149 and weight is 37. So this girl is not bad in terms of height. It's very close to her parental height. Breast stage is there, but pubic hair is stage 3. LH, FSH is low. So this is a discrepancy between pubarchy and thelarchy going more in favor of a hypogonadotropic hypogonadism. She also gave other clues of anosmia and deafness, which suggest a possibility of Charge syndrome or CHD7 defect. So if you have a discrepancy in which pubarchy is present, but thelarchy is not there, think of a hypogonadotropic hypogonadism. And if there are features like anosmia and deafness, you may get a direct clue for Charge syndrome, like in this case. 17-year-old girl with secondary amenorrhea, in this case was alluded to by Dhwani in terms of her presentation, and we were sent to us as a large pituitary tumor. But when we saw the child, she had a high prolactin with galacturia. This was labeled quote unquote a prolactinoma. But the child had all the features of hypothyroidism. Her FT4 was very low, TSH was exceedingly high, and this was a classical case of pituitary hyperplasia, a thyrotrop hyperplasia because of hypothyroidism. And once we corrected it, there was an improvement not only in clinical features, but also in terms of other clinical scenario. 14-year-old girl with delayed puberty, no breast, no pubic hair, no periods. Her height is 144, weight is on the higher side for the height. FSH is slightly high, but not as high as Turner syndrome. LH is slightly high, karyotype is X6. So what else to look at? And here also Dhwani gave you a clue that pseudo-hypoparathyroidism may present with a resistance to gonadotropin. So she had got a brachymetacarpia, there was deafness, there was hypocalcemia, hyperphosphatemia, and high PTH, suggesting pseudo-hypoparathyroidism. So this is something you have to be worried about in that regards. 14.5-year-old girl with delayed puberty, no breast, no pubic hair, height is 145 centimeters, weight is 36 kg on the lower side, FSH is high, LH is normal, karyotype is XX, there is hypertension. So this is a very, very interesting scenario. You have a girl who has got delayed puberty, sexual infantilism with hypertension, and your karyotype is X6. So I think this is a clear-cut clue that you're dealing with a 17-hydroxylase deficiency. So subtle clues like looking at blood pressure can give you the right diagnosis in that regards. We have developed a puberty interpreter, which is a mobile application-based app which provides guidance with regards to evaluation of puberty based upon very few clinical inputs, based upon all the algorithms which we talked about. And once we validated it, we found it to be highly effective in terms of preventing unnecessary workup and missing of pathological causes from that regards. What we can do theoretically is we can give estrogen, of course, to induce puberty, which is the most likely treatment. We can think of gonadotropin treatment in somebody who has a hypogonadotropic hypogonadism. There are studies which have looked into GnRH pump-based therapy and the use of kisspeptin, but predominantly we will focus on estrogen and gonadotropin for fertility in hypogonadotropic hypogonadism. If somebody has an ovarian problem, we of course can only give estrogen. In certain scenarios, specific therapy may be possible. For hyperprolactinemia, they will respond wonderfully to D2 receptor agonist. If there is a prolactinoma, macroprolactinoma, long-term treatment, microprolactinoma, up to 2 years treatment is required. Anorexia nervosa, we have to do a nutritional rehabilitation. Once the weight becomes more, they will have increase in fat and the periods may happen. Celiac disease respond dramatically to gluten-free diet. Systemic disease, specific treatment is required. Now, estrogen, the route is very important. We have an option of either giving estrogen via the oral route, wherein it goes to the liver and then reaches the circulation, or we give a topical scenario in which we just apply. So when we give orally, it is going to the liver. It is affecting IGF-1 production, resulting in lower level of IGF-1, increased level of protein C, resulting in thrombotic tendencies, increased lipase, resulting in dyslipidemia. So oral preparation may have a lot of complications in that regard. Transdermal preparation, on the other hand, will directly result in the delivery of estrogen to the blood. They will not have an effect on IGF-1, thrombosis, dyslipidemia, or hypertension. These are the agents of choice, but they are not readily available and are expensive in that regards. So we have an option of transdermal versus the most commonly we use is 17 beta estradiol. The dose is 2 milligram per kg per day. We have to start from a very, very low dose. The effect on IGF-1 is of course more with 17 beta along with hypertension and thrombosis risk as we have discussed in that perspective. So the estrogen preparation which was earlier used was ethinyl estradiol. The adult dose typically is around 10 to 20 microgram per day, and typically we should start from around 10% dose. But this is a very strong preparation. We should better avoid ethinyl estradiol. What we use is ethinyl estradiol valerate. In that, we start off with 0.25 milligram and then build up to adult dose of 2 milligram over a 2-year period with a physiological development. Transdermal estrogen, the options are to start off with 3 to 7 microgram per day by cutting the patches and applying that on alternate days to begin with, and then gradually build up to the adult dose. The benefit of transdermal estrogen is that it doesn't have an effect on IGF-1. In girls who have constitutional delay of puberty and growth, if they are getting too late, we may push the puberty by giving a small dose of estrogen, like we give testosterone in boys, 0.25 to 0.5 milligram daily for 3 to 6 months. And this often kickstarts the puberty in that scenario. Those who have a permanent hypogonadotropic hypogonadism or hypergonadotropic hypogonadism, we start with 0.25, build up over a 2-year period to a 2 milligram dose, and then only considers adding progesterone. If a progesterone is given at an early stage, it compromises the breast and uterine development and should therefore be avoided. The fertility option in hypo is gonadotropin, which we'll discuss a bit later. For hypergonadotropic hypogonadism, the ovarian problem, we can think of a oocyte donation. Progesterone should be added only around 2 to 2.5 years after the onset of pubertal induction, and we could give it or the periods have happened. The options are medroxyprogesterone or micronized progesterone. Micronized progesterone are preferred, but they are more expensive in that regards. They should only be given either at vaginal bleeding or the endometrial thickness is more than 5 mm, because too early progesterone prunes the breast development and the uterine development as discussed. So for self-limited delayed puberty, start around 13 years and a bone age above 12 years. Start with estradiol valerate at 0.25 to 5 milligram for 6 months and gradually look for pubertal response, and you will find an increase in LH and breast development, and this will be usually a process which will improve. For permanent HH, we start off around again at 12 years of age. The protocol is estradiol valerate 0.25 milligrams, increased by 0.25 every 6 months to adult dose of 2 milligram by 2 to 2.5 years. The follow-up will be to look at growth, progesterone if there is a bleeding or the endometrial thickness is more than 5 mm. Breast size, however, will remain compromised with multiple pituitary hormone deficiency. We typically have periods by around 2 to 2.5 years, and we have to monitor blood pressure in that scenario. For hypergonadotropic hypogonadism, the options are oocyte extraction and donation, but often by the time they come to us, the oocyte is already not there. So most girls with Turner syndrome don't have that option. Oocyte donation therefore becomes an option. And oocyte extraction can be done after 12 years, but it's an invasive procedure. The future direction, of course, is ovarian transplant and stem cell.